So we're going to talk about fate. We're going to look at the basic views. So we have the subcostal window, which is, if you think about it, is actually very, very easy to get, and it should be your first one, because if you get a good subcostal view, you get most of the information that you need. The only problem that I will tell you that this has is that in an awake patient can be uncomfortable, because you're basically digging in, you're pushing in, so some patients may not like it. Some patients may have a big abdomen or a big distended belly that it makes it tricky. But a good subcostal is actually very good, and you should be able to get this very easy. Apical views are nice because they're classic. You see the 4-chamber view, and that's actually very easy to understand. It's a little bit trickier to do, and I'm going to show you some of the tricks. And again, it helps a lot when you get a good one. Parasternals are actually consistently very good windows, and you can get a lot of information. This is a window that cardiologists will use to get your EF routinely in most patients. And you can, by modifying the position, the angulation of a probe, you will get some of the views that I'm going to show you that are very, very good. And then you got the pleural views, which is going to not just look at the lung, but also looks at the intra-abdominal content, which is also very important as well. And again, that's those different windows. We go with particular views, and we're going to go one by one. I'm not sure if they gave you a brochure that was supposed, I don't know if your paperwork, did they get a copy of the FATE? We should be able to get you this, guys, but it's in the internet. You just Google it and you get it, because what happens is that my residents eventually print this, and they have this cheat sheet, and they kind of do their echo exam. It's very, very nice to have it at the bedside when you're doing this for the first time. Okay, and again, we're going to review the extended views in another lecture. And again, it's pattern recognition. You have a question, the machine should, well, the images should be able to answer those questions, and they have to be done in the clinical context. So subcostal view. You put your probe under the Seifert process, you push a little bit. The probe has a marker that gives you left and right orientation. The marker for this view has to be towards the left shoulder of the patient, like you see here. It helps if you ask your patient to bend their knees, because that relaxes the abdominal muscle, so you can actually push it in a little bit. It also helps if you ask the patient to take a deep breath. As they take a deep breath, their heart goes down, and you can see it better. So respiratory maneuvers will help you. Different respiratory maneuvers, depending on where you are, will help you or hurt you to get a better image. In this case, taking a deep breath will take the heart closer to your probe, and you may get good images. Okay? This is how it looks. You're using, if you pay attention here, there's a little bit of liver here. The liver goes, as you can see, all the way here. So you're using your liver as an echo window. Okay? If you happen to have stomach or a viscera there and it has air, the image is very degraded because it won't get transmitted through air. But if you have liver there, it actually looks very good. So sometimes, if your window in the subcostal view is not perfect, move a little bit towards the right of the patient, towards the liver, and try to use the liver as the conductance of ultrasound, and you may improve your image. And what you see here is the right-sided cavities. These are the left-sided cavities. And you have them here. This is the RV, tricuspid here, RA. This is your LV, mitral, and the LA. And again, this view alone gives you a lot of information. We give you a live view here. Because you can see, is there an effusion around the heart? No. That bright line that you see here is pericardium. Is the heart contracting or not? Yes, the heart is contracting. You can even tell this heart might be a little bit thickened. Okay, it's a little bit of hypertrophy just from eyeballing it, not even measuring it. Okay, the right heart doesn't look bad. It doesn't look dilated, and you'll see it when the right heart dilates. It's obvious because it becomes bigger than the left heart. So you should be able to pick up things. So a good subcostal view gives you a lot of information. Okay. So what do you do with your subcostal view? You move your probe now, the marker that was pointed towards the left shoulder, you move it towards the ceiling, okay? And that's going to give you a modified version of this view, which is going to give you the entrance of the IVC into your heart. So you see the confluence here of the IVC and your RA. And the reason we like to do this modified vision of the IVC is we try to assess volume status. And I'm going to talk about that a little bit more in the next lecture. But just by rotating the probe 90 degrees and aiming a little bit towards the liver of the patient, you get this modified view. And I'm going to go through some of the issues of this view in the next lecture. But very simple. Subcostal, you get your modified 4-chamber view. You move 90 degrees towards the ceiling, and you get this view. This is the subcostal IVC view. And you can see the marker here. And this is what you should see. Most of the measurements we do at the IVC should be done like a centimeter, centimeter and a half from the RA. You have to make sure that this is the RA. The aorta is just behind this, and sometimes can be easily confused. And that's why one of the things that they ask is please be sure that when you're looking at this vessel, it enters the right atrium, because it can be easily confused. And I'll show you an image with the aorta as well. And this is how it looks. See the liver, IVC, and you see this is the right atrium. And again, you're going to try to use not just the diameter of the vessel, but also the pattern, the changes in diameter of this vessel when you're breathing. And we'll talk about that in the next lecture. Now you move your probe towards the apical views. You've already done subcostal views. We're going to go to apical views. You go to your point of maximal impulse. If you have a patient that you think has a normal heart, you're basically going to go in the same anatomic patterns. If the patient has a dilated heart, you may want to go a little bit more lateral for this. The marker of the probe should also be pointing towards the left shoulder of the patient. Okay? And this is what you should get. If you happen to have the probe just at the apex of the heart, this is what you get. This is a 4-chamber apical view. Okay? It's actually a very powerful view. It allows you to understand what's going on with the heart in a simplistic fashion. One of the things that we do for this view that helps you get a better image would be to turn the patient towards the left side. You'll see this in the echo labs. They always ask the patient to tilt towards the left side, and that helps you, brings their heart closer to the chest wall. You can ask the patient to exhale and hold it like that without air. That also helps. When you take a deep breath, the image kind of gets very blurry. When they exhale, it gets better. So again, you can use positioning and breathing to assist you in getting a better image. And this is what you should be getting. Again, the structures are very easy to recognize. This will be your lateral wall, septal wall. This is your mitral valve, your LA. You can measure here all kinds of diameters if you want to assess dilation or volume status. You can check, you can put Doppler color here to see if you have MR or TR, all kinds of things. You can see the relative size of both cavities to assess whether the right heart is dilated or not. Very powerful view, very powerful view. And this is how it looks. And again, it's not a bad thing to have EKG attached to it. Some of the ultrasound machines that we do for this, for the surface echoes, don't usually get that. If you're getting an exam that is going to be recorded for the cardiology department or for the record of a patient, most commonly they have an EKG. It helps you a little bit when you're doing some Doppler measurements and things to know where you're on the cardiac cycle, and you use EKG for that. So we've done subcostal, apical. Now we're going to go parasternal. We have the long axis parasternal view and the short axis parasternal view. Now the probe sits probably in the third or fourth, between second and fourth intercostal space, besides the sternum. The marker now will point towards the patient's right shoulder. Okay? That's important because it's going to give you the orientation that cardiologists use. So we're trying to standardize how the views are presented. We don't want to have the heart in all kinds of positions. Everybody does what they want. So we standardize that so we can have an image that we can recognize. And this is what we get. The top here, this is the RV. This is the interventricular septum. This is the aortic valve. You see your mitral. LV here. This is your LVOT, as you eject blood here. This is the left atrium. This is usually a very reliable view because your work on the second intercostal space, you have very little lung in between. Really, it should be relatively easy, and you get it basically in a neutral position. You don't have to do many positioning or breathing manipulations in this scenario. And again, these are the structures that you can see. So you can tell if you have aortic insufficiency, you're going to see the jet going here. If you have mitral insufficiency, a jet going here. If you happen to have an effusion, you'll see it. Okay? So again, these are powerful things that takes just one view and you make the diagnosis. And And this is how it looks when you do it live. Then you can twist your probe. Now your probe is going to go clockwise, and you're basically going to aim the marker that was pointing towards this shoulder. You're going to aim towards the other shoulder. The idea is to cut the heart now in a short axis view. You're getting a slice in the long axis view. You're going to get a parasternal short axis view. And this is going to give you a very easy recognizable view, which is your short axis parasternal view or your mid-papillary view. You see here the LV, you see the papillary muscles here. It's a good way to assess contractility and also volume status, okay? At the same time, you can even see the different regions of the heart. We're going to talk about that in the next lecture. So if there's a problem with a particular coronary, certain areas are going to go down, and you can see that and have an assessment of where could the problem be in terms of coronary location, okay? And this is how it looks. And again, this is real images. So you can see sometimes you have a lot of dropout here, and you start, one of the things that you have to understand is that your images may not be perfect. So if you get an image in one particular window that doesn't work, go to the next one. The whole idea, the whole premise is that by going through the different windows, you should be able to get the information that you need. Okay, so don't get discouraged. Some people have horrendous windows, and they'll tell you when you read those reports, exam technically difficult, you know, and it's because the patient, I don't know, it's either a COPD that has lung everywhere, or it's morbidly obese, et cetera, and you'll be impressed. Some people that you think, when you see them, you think, oh my God, this is going to be tricky. Wow, you get beautiful images. And the other way around, you got a skinny patient, you think everything is going to be a piece of cake. And the images are terrible. The windows are terrible. So again, it's one of those things. But I will tell you, if you get into a window and it doesn't work, move to the next one until you get the information that you get. I will tell you that if you follow all these views, you're going to get what you need. Last but not least, it's going to be the pleural abdominal views. What you do in this scenario, the marker is going to go now towards the head. Depending on where you are, right or left of the patient, you go towards the marker towards the head of the patient. And you're going to scan up and down, and you're going to try to look for particular reference points. One of the things that is very echogenic is the diaphragm, and you'll see it. So it becomes, here it didn't come out as good, but it's a very, very bright line, and you'll see it. So you're just going up and down, until all of a sudden you see the bright line, that's usually a diaphragm. You're going to see a structure that is basically big. If you're on the right, that's going to be the liver. And you may be able to see the kidney as well. Important structure, because you can rule out the patient's not making urine. You go here, and then you see a dilated kidney with hydronephrosis. That's easy. That's very nice to do, okay? Or you may see fluid in between here, the Morrison's pouch, and then you say this patient is having a collection of fluid inside the belly, okay? It can be ascites, it can be blood, depending on the clinical context of what you're doing. So it's very, very powerful. And you see, this is better. You see how bright the diaphragm is, and you can see how it's moving with breathing. Then you can see your liver here, and look at the kidney. Very easy to recognize, okay? You should be able to get this in most of your patients. And also, when you're looking at here, you can modify some of your views. This is more into the lung ultrasound that basically is not necessarily part of the FATE exam, but I think it's so powerful that I think we're using it more and more. And it's to put your probe between the ribs. So you get your linear probe, the same they use for your regional procedures, and just put it between the ribs. So you're going to get this image. So it's interesting, because now you're going to have the following scenario. You're going to use all the artifacts that you have to make a diagnosis. Air does not transmit ultrasound, and you're going to use that to your advantage. It used to be that we thought that we couldn't use ultrasound for the lung. Yes, we can. I'm going to show you some examples of that. So if you put the probe in a longitudinal fashion, you get a rib and another rib, okay? And then you see this bright line here. This is a pleural line. And what you have down here should be the lung. People have called this the bad sign. It's sometimes a little bit tricky to see, but you're supposed to have the, oops, it didn't show up. Let me just go back. Let me see if I can show you again. Well, a little bat is supposed to come here. And you can see the wings, the wings of a bat here. This is the body of a bat. I'll show you in the lung. The pleural one is it's more clear. And also, you're going to see things moving. If the lung is moving, you're going to have this thing. These are the two pleurals moving. It's called the sliding sign, and that tells you there's lung underneath. So if the patient is hemodynamically compromised and you think there's a pneumothorax, you put your probe, and you see this sliding sign with some of these bright lines that go down, they're called comet tails, you rule out a pneumothorax. And it's much better than even an x-ray. Okay? Remember that when your patient is supine, there's air in the cavity, the air will go to the top. An x-ray may miss it altogether. You get an x-ray, you're going to see lung parenchyma underneath if it's a small pneumothorax, and you may miss it altogether. Echo will allow you to make the diagnosis right away. And again, I'm going to go into some of the other views. If you do M mode, when you're looking at the lung, there are going to be particular signs. I'm going to tell you. You need to get exposed to this terminology, particularly the residents, because this information is going to be coming in your exams. Okay? I think in the last in training, there were a bunch of questions on echo views that I think were important for the test. So I think, again, it's one of the things that we will review. So again, you have these 4 windows with all these different views: subcostal, apical, parasternal, and the pleural/abdominal view. You should be able to get the information that you need quickly. And this is a simplified FATE exam. So the good news is you can do this independently of how the patient is sitting or lying on the bed. It can be done very quickly. And again, pattern recognition. I'm going to say this over and over again because that's basically what it is. And again, the pathology should be very easy to recognize. At the end, this afternoon, when we do all the skill stations, I have, if you bear with me, I'm going to probably over 40 minutes, we're going to go through some pathology. And the idea is for you to recognize the pathology and on the slides that I will show you. You'll be impressed. You should be able to diagnose what I show you in the images. These are images for you to diagnose, and you're going to see that at the end of the session, you should be able to recognize 95% of the pathology.